It's week 15. Coders, let's go. We have one more week. And this week we'll be covering CPT Radiology and Path and Lab. And you know what? We won't have time to get into medicine. So we've already uploaded it in your playlist. And because we don't have much time, I'm not going to do a lot of talking. I just want to tell you, stay sharp. Stay focused. You're almost at the finish line. And we can't go anywhere without doing a quick shout out to the AMCI team and our amazing interns. You keep the course running strong, and we appreciate every single thing you do. Okay, coders, coders, drop a thank you in the chat to the team. And just want to quickly remind you that we do have a disclaimer. If you are new to coding, go ahead, click on the syllabus, and locate these beginners lectures, these CPT beginners lectures. What's going on at AMCI? Well, we have one more week. That's what's going on. But we're not going to get into how to prep for the CCS. We're going to save that for next week. But yes, it is time to exam prep. And don't forget AMCI Friday Night Live. We do Jeopardy, Hangman, and Wheel of Fortune, and there's a new time. We begin at 7 p.m. Eastern, 6 p.m. Central, and 4 p.m. Pacific. And don't forget about Introduction to IMTAP, also in Discord. And it's Introduction to Medical Terminology and Anatomy and Physiology. So check it out on Wednesdays. If you're a member of Discord, you can come, and it's lots of fun. And the instructions on how to join Discord are in what's on your syllabus, okay? So go to the syllabus and follow those instructions. Also, these are the books for weeks 19 through 16. And today, yes, we'll be using CPT 2025. You may use your HCPCS level 2, your Bucks step-by-step manual. If you can't afford the 2025, you can get 2023 or 4. The MCG 2025, if you want to save a little money, go ahead and purchase the 2024. And yes, we are pressed for time. That's why I'm kind of moving a little fast at the beginning, but I don't want to forget to say thank you. Thank you to all of you that are sharing this course. We see you. Right. CPT is copyright of 2025 AMA. All rights are reserved. Keyword concept FTR CHUN, AMCI Fab 7, AMCI ICD 10 CM Philip TAP, and MCG are registered trademarks of AMCI. CPC, CRC, COC, CPMA, CPB, CPPM, CPCO, and more are owned by AAPC. CCA, CCS, CCS-P, RHIA, RHIT are owned by AHIMA, and AMCI does not own the rights to these credentials. Goals of the presentation for week 15. Number one, we're going to review CPT radiology coding. Number two, CPT pathology. Number three, we won't get to medicine, but we did provide it for you in your playlist. And we're going to give you practice exercises to test your knowledge and bring you one step closer to CPT coding mastery. If we haven't said it over and over again, guidelines are key. It's what distinguishes certified coders from others, from non certified coders. It is your understanding and ultimately the mastery of these guidelines. So the MCG manual helps you learn them, helps simplify them. In fact, we've created these FTRs, facts to remember, and they're all compiled in MCG manual. So let's take a look at radiology. So if you go to the radiology from your table of contents, click on radiology FTRs, and boom, here you are. There are only 3 classifications, so there aren't a lot of guidelines, but let's go ahead and review. So if you are coding anywhere in the radiology section, you're going to need to know these items. They may or may not apply, but you need to know them. Also, too, I want to draw your attention to this hyperlink. Don't forget, this is an instructional video. We call it a CHUN video. It's extra. They're older, but they're very valuable. So if the codes aren't in there, don't blame us. We just gave it to you because we wanted you to have this instruction. It is good. It's better than this instruction that I'm giving you, especially if you're new to medical coding or if you want to study the guidelines. All right, so when radiology coding, here are the facts to remember. Number one, pay attention to technique and location. If we're saying technique, we're talking about the type of imaging. What type? Is it a chest x-ray? Is it a CT scan? Is it an MRI, etc.? Location, location on the body of the beam, etc. Also, you'll need to know the planes, right? So, and we're going to discuss these planes. You have frontal, sagittal, transverse, superior, and inferior. These are radiologic planes. Well, we're going to call it radiologic planes. Also, understand radiographic beam positions. What's AP, PA, and lat, oblique. Also, you got to know the body positions. Supine, prone, lateral. You'll need to know the radiology um, modifiers or those components, right? They have 2 modifiers. Also, supervision and interpretation, how to apply it. Also, you got to watch with and without contrast. And remember, contrast, if they insert it orally or rectally, you do not use the with contrast codes. Also, um, there are just some reminders that CT and CTA are different, right? MRI and MRA are different. Also, spine imaging. They use with contrast, and that does include intrathecal or intravascular injections. So just to make sure you know it. And you know what? I'm going to help you because we're going to review some of these. So let's go ahead and begin our discussion of radiology. Now, let's go ahead and talk about anatomical positions. In fact, I want to teach you about the 3 Ps. What are the 3 Ps? Planes. This is how the body is divided. Position, how the patient is placed, right, for that projection. And the projection is the path of the X-ray beam, the 3 Ps. All right, so we'll begin with planes, right? So this is basically how the body's divided. In number one, this is your transverse plane. It's a horizontal plane that divides the body top and half. So in half that way. Number two, frontal plane divides the body in half but front to back. And number three, mid-sagittal plane divides the body in half but right and left. Got it? Next, let's talk about positions. You're going to need to know these positions not just for x-rays, but for procedures, surgical procedures. The first one is prone position. The patient is lying face down on the front of the body. Number two, this is supine, right? Lying down on the back with the face up. Number three, this is lateral. The patient is lying on the side. In number four, oblique position, the patient is lying down at an angle. Got it? I know you do. Now, projections, the final P. The projection is how the ray or the beam enters the body, right? So if this patient is lying supine, the first one, and the projection goes in, it's going from front to back, right? And we call this antero-posterior. Antero-posterior. Ooh, AP. So front to back. Now, in the second, the beam is going through the back to the front, right? So if it's back to the front, it's posteral anterior or PA. And the third one, the beam is going on the side. This may not be a good example, but trust me, this is in front of the patient. This beam thing is in front of the patient, and therefore it's taking a lateral view of this patient. And they all seem to be chest x-rays except this last one, or maybe not. This last one is at an angle, right? So it's oblique. So that angle, that beam is going in at an angle. There you go. Now, when you are coding, you're going to need to know how many views these are. And just so you know, AP is one view, PA is one view, lateral is one view, and oblique, that's one view. So I want you to tell me how many views there are. All right. So if a patient had an AP, then they got up, did a PA, how many views? If you said 2 views, you got it. You got it. All right, one more time. How many views? If a patient had an AP, a PA, and a LAT, how many views? If you said 3 views, way to go, way to go, way to go. All right, so I'm going to show you how these are coded. All right, so I'm going to demonstrate a scenario. And if you want to code it, go right ahead. I encourage you. All right, a patient had a continuous cough producing green mucus. The physician wanted to rule out pneumonia. She ordered an AP lat of the chest. Code the encounter. All right, coders. So you're going to have to locate your code. So if you're looking up in the index, go to X-ray, then chest. Then it's going to tell you the code series. Go to that code series and you'll see this, right? So let's take a look at the codes in this series. Radiologic examination, chest, single view. That's 71045. For 6 is 2 views, for 7 is 3 views, and for 8, that's 4 or more views. Okay, coders, what say you? If a patient had an AP lat of the chest, they had 2 views, and your answer would be 71046. Now, in the general scheme of things, that would be your answer. Now, we're going to just quickly look at these guidelines, and then we're going to talk about modifiers. And the guidelines are so important. Just like surgery coding, radiology coding has specific coding guidelines and general. Let's go ahead and take a look at the general coding guidelines. All right. So these general coding guidelines on these green pages, I want you to know that when it's the green pages, they are general and we follow the same rules in CHUN, right? So these green pages are general. Let's address each of the green ones. So essentially, subject listings says that these codes can be used by radiologists or physicians, or a qualified healthcare practitioner, or someone supervised by these providers. Also, separate procedure has the same exact meaning as the surgical separate procedure. When a procedure or service is designated as separate procedure in parentheses, is carried out independently, you don't have anything to worry about, just coded. However, if it is coded being carried out along with another related procedure, it gets bundled. However, if it's significantly separate, you're going to go ahead and append modifier 59, same exact guidance. Now let's move on to unlisted service or procedure. Here are the codes. Let me get my pointer out. And when you use these codes, often they don't say what it is. So you'll need to incorporate or include a special report that further explains what was done. Often just, if a surgery took place in addition to this procedure, or a radiology report. So speaking of surgery, supervision and interpretation image guidance, this is pretty much when surgical procedures require imaging. You get to code the imaging also, and this is supervision and interpretation imaging guidance, or RS&I, an RS&I purpose. Not necessarily a code. These codes can be used. You just don't need to append a modifier. And down below, you've got administration of contrast material. Yes, this is where I got the guidance that you cannot code contrast, use the contrast code if oral or rectal contrast was administered. And then we're moving on to written reports. This is pretty much guidance for providers on what needs to be included in the reports. And finally, the foreign body versus implant definition. The reason this is essential, you pretty much know what a foreign body is and what an implant is. Often, implants sometimes can become foreign bodies. Here's how. An implant is something that is intentionally placed in the body by the physician. Intentionally is your key word. Anything unintentionally placed, it becomes a foreign body. Okay, so let's say a doctor put an implant that had screws and bolts. And let's say the screws and bolts came out and they dislodged somewhere else. So initially, that implant was placed to, I guess, let's say for a fracture, to treat a fracture. But when it malfunctioned and the screws dislodged and implanted somewhere else, it's now a foreign body. Okay, I hope that makes sense. Okay, coders, so these are our general coding guidelines. Now I want to switch gears and I want to talk about modifiers. Specifically, modifiers 26 and TC. TC is for technical component. 26, well, that's for your professional. That's your professional component. Now, we've already discussed this in week 9. So if you go back to the playlist, look at week 9, you'll see a more extensive discussion. But right now, I just want to kind of summarize the main points, and I want to test your knowledge of modifiers 26 and TC. And we have a gem. These are the rules, the AMCI rules for distinguishing the professional and technical components, right? Let's begin with the physician or the professionals. They use modifier 26 if they provided the professional component of this global code. In other words, they only read and reported the film. They didn't do anything else. They provided their professional services. And when that happens, they append 26 modifier. Now, let's turn our attention to technical component. And technical providers or companies use TC when the hospital has contracted with them for their equipment, their technical services. For instance, the hospital that I had my MRI, they contracted some MRI company to do it. So that MRI company brought their truck up, backed it up to the radiology department. I walked in, had my MRI, and boom, that technical provider, that MRI company, they got to use the global code 70551 and they appended the TC modifier at the end. Now, the hospitals, they don't have to append a modifier. In fact, they don't append modifier. They get to use the global code because they provide several of the components of that radiologic service. Like what? They employ the entire team. They provide the supplies, etc. Now, if the physician owns the equipment and reads the report, so if the physician provides the technical services and the professional services, and they own that equipment, they get to use the global code as well. All right, I hope that makes sense. And if it doesn't, maybe this application to practice may help. All right. So we have Amy arrives to the ED with a continuous cough producing green mucus. The physician wanted to rule out pneumonia. So she ordered an AP lat of the chest carried out in the X-ray department. A radiologist from ABC Radiology Group interpreted the results. Code for the radiologist. All right. So if we are coding for the radiologist, and if we use this little rule sheet, the radiologist is the professional, right? And if the radiologist is the professional, it says physicians have to use modifier 26. So we would append modifier 26 to 71046. Yes, 46. AP lat is 2 views. All right. Did you get it? Let's see how this one goes. Amy's at the ED with a continuous cough producing green mucus. The physician wanted to rule out pneumonia. She ordered an AP lat of the chest carried out in the X-ray department. A radiologist from ABC Radiology Group interpreted the results. Code for the hospital. All right, that is our task. Code for the hospital. And coders, as a side note, this is the reason why we read the last question first. So you know what the task is. There's a lot of words there sometimes in that documentation, and sometimes we can get caught up. So that we're focused, we tell you to read it first. And we need to code for that hospital. All right. So I'm going to just kind of visit the rules. And the rules say that hospitals have no modifier, right? So if hospitals have no modifier, our code is 71046. I'm going to let that marinate. I hope it makes sense. Okay, we've got one more. All right. So the X-ray equipment is owned by DEF Imaging. Code for deaf imaging, right? So look at this. Code for deaf imaging. Right away, we knew what to do. And also, I want to tell you, there's a lot of instructors out there who are telling you to just kind of skim read the last question and then do the answers. Don't you dare. An AMCI student better read all of that documentation. Radiological supervision and interpretation, or RSNI, I think this is being made more complex than it is. Essentially, this is what it is. If a provider uses radiology to carry out a surgical procedure, then you code both if the surgery code does not include it already. That's it. Yes. So if it's used and it's not included, then you code the radiology code. And you're going to report two codes. You're going to code for the surgery, and you're also going to code for the radiology. Procedures like vascular angiography, you're going to code for the angiography, and you're also going to code for the vascular procedure that took place. All right? The cardiac catheterization, you're going to code for the catheterization, and you're also going to code for the guidance used to place the catheter. That's it. And here is the gem. Pretty much, if the surgery code description includes phrases like with image guidance, or with fluoroscopic guidance, or with RSNI, don't report imaging separately. I'm going to let that marinate. Yeah, so pretty much when you have radiology, when you're coding for radiology and surgery, that's considered interventional radiology. And I'm going to let that marinate. All right, so now it's time to move on, and we're going to test your knowledge, right? And I'm going to ask Mr. Sandeep to come to the fore. Okay, Mr. Sandeep, please and thank you.
Start by doing some coding exercise. So, are you ready, coders, for some coding exercise? I know you all are. And here's your first coding scenario for the day. So, what CPT codes are reported for the physician services? Options are option A 36556 76937 with the 26 modifier, option B 36558 76937, option C 36556 77001 with the TC modifier, option D 36558 77001. A 56-year-old patient who has been admitted requires a central venous catheter insertion. The physician uses ultrasound guidance to perform the insertion. The physician documents vessel patency and that permanent recordings are in the patient's record. What CPT codes are reported for the physician services? So, coders, you got, I think it's 2 minutes. You have got to answer this one. See you after 2 minutes. All the very best. And I believe that is time. And let me quickly look into the chat and see how you all are doing. Okay, it's good so far. Okay, let's start solving this scenario, coders. So let us start by highlighting the keywords for this scenario. We have a 56-year-old patient, central venous catheter insertion. Physician uses ultrasound, vessel patency, permanent recordings, physician services. So we are coding for the physician services over here. And in the inventory, we are having CV catheter insertion, ultrasonic guidance, permanent recording. So that's all we have. And I have listed out the code options as well. So I want to re-emphasize on the importance of churning, how it helps me to solve the scenarios and quickly get into the answer. So you can see the codes 36555 and 36556 is coding for insertion of a non-tunnel central venous catheter. The same time 36557 and 36558 is coding for an insertion of a central venous catheter. So that's the main difference between these two families. So now let's talk about what's the difference between insertion of a non-tunnel central venous catheter and insertion of a tunnel central venous catheter. So insertion of a non-tunnel central venous catheter means the catheter is inserted superficially. Yes, it is inserted straight through the veins. At the same time, if you look into the insertion of a tunneled central venous catheter, that means the catheter has to be, yes, it has to be burrowed much more deeper, and it is tunneled through the skin before it's reached the skin. And that is the main two difference between a non-tunnel centrally inserted catheter and insertion of a tunnel central venous catheter. And also for digging, for the burrowing more deeper, you need a guidance. So most probably in most of all the cases, we use guidance such as ultrasound guidance or fluoroscopic guidance. And that is something which we can look into the scenario and see what's the difference, which procedure has been performed, whether it's a tunneled centrally inserted catheter or it's a non-tunneled centrally inserted uh, venous catheter. So coders, question for you. Looking into the document, what do you think? Whether it's a centrally tunneled inserted catheter or non-tunneled catheter? There you go. Yes. Because you can also see that physician uses ultrasound guidance. So as I've said already, for a tunneled centrally inserted venous catheter, central venous catheter insertion, we need a guidance, and that is ultrasound guidance which doctors use in this scenario. Yes, which means option A. And option C is incorrect, which is coding for insertion of a non-tunnel central venous catheter. And also option C is coding for a TC modifier. TC is for a technical component. And we are not looking into a technical component here. So option A and option C is incorrect. We are looking for physician services. So that leaves us with option B and option D. And option B is coding for 76937, which is for an ultrasound guidance. And option D is having 77001, which is coding for a fluoroscopic guidance. Yes. So from the question, from the scenario, it's been documented that the physician used an ultrasound guidance. And that means option B is the correct answer. And again, a gentle reminder on what a TC modifier and a 26 modifier is. In TC modifier, the provider you are coding for owns the equipment. And in 26 modifier, the professional is only providing professional services. That means the professional will be reading out or interpreting an image such as an ultrasound image or an X-ray image. So that's the difference between a technical component and a modifier 26. So here we have an ultrasound guidance used. And also this involves a supervision of an interpretation. Even though the code language doesn't say that, under the supervision and interpretation image guidance, there is a guideline which states that all the radiological supervision and interpretation code require 1. Image documentation in the patient's permanent record, 2. A procedure report or a separate imaging report that includes written documentation of interpretive findings of information contained in the image and radiologic supervision of the services. So in our scenario, yes, we have the doctor has been, it's been mentioned, doctor used ultrasound guidance, and physician also documented the vessel patency, as well as there is a permanent recordings that are in patient's records. So both the criteria are met, and there is a supervision and interpretation as well involved. So there is no record, there is no need to code a 26 modifier. Yes, you are correct. Yes. So let's move on. And also we can use this table, the central venous access procedure table as well. So you can see the code 36555 and 36556 is for non-tunnel central venous access catheter insertion, and 36557 and 36558 is for insertion of a central tunneled venous catheter. So you can use the table as well. Okay, coders. So with that done, I believe it's time for next challenge. And here's your next challenge. How would you report for the professional services of this study? Your options are option A 77078 with the 26 modifier, 77080 with the 26 modifier. Option B 77080 with the 26 modifier, 77081 with the 26 modifier. Option D 77081 with the 26 modifier, 77080 with the 26 modifier. Sally had a DXA bone density study for her hips, pelvis, and spine. The procedure was performed in a hospital. How would you report the professional services of this study? And coders, your 2 minutes starts right away. All the best, coders. You guys are rocking in the chat. Great, great, great coding. So we have DXA, bone density study for the hips, pelvis, spine. And what are we coding for? We are coding for professional services of the study. And we have in our inventory DXA bone density study of hips, pelvis, and spine. And as I said, we are coding for professional services provided. So these are our code options. And once again, I have done churning, which is going to help me quickly pick my correct answer. So you can see the CPT code 77074 to 77075. It's for an X-ray. 77076 is for X-ray. 77077 is for X-ray as well. And 77078 is coding for a CT. And the code series 77080 to 77085 is for DXA. Yes, it's for DXA bone density study. Okay, with that given, we are looking to code for a DXA bone density study done for hips, pelvis, and spine. That means option A is incorrect, which is coding for 77078. That is for a CT scan. That is for computer tomography, bone minerals density study. And we are not coding for a CT study here. We are coding for a DXA bone density. Now let's look into the next option C, which is 77081, and that is coding for, yes, that's coding for DXA, which is a dual energy X-ray absorptiometry. Yes, but it is not coding for the correct location. It's coding for appendicular skeleton, peripheral, which is a radius, wrist, heel. But we had a DXA bone density study of hips, pelvis, and spine. So the location is incorrect. So option C is also wrong. And the two remaining options are option B and D. But straight away looking into option D, I can say that's wrong. That is not going to be correct because that's coding for both a 26 modifier and a technical component as well. So that is not possible at all. Yes. And 77080, there's no need to code them twice. We are coding only for the professional services as well. So there's no question a technical component is going to come into the frame. So option D is incorrect, and the correct answer is going to be option B, 77080, which is for DXA bone density study of one or more sides. So we have hips, pelvis, and spine. So only need to code one time, and that is for hips, pelvis, and spine. So how are you all doing, coders? Okay, I can see only option B in the chat. So I know that you all are doing pretty well with this scenario. So how about another scenario? Are you ready, coders? Doing good? Yes. Fully energized. We have fully energized coders here. Okay, let's move on to the next question. Yes, here's the question number 3 for you. What codes should be used for this procedure? Your options are option A 76815, option B 76816, 76816 with a 59 modifier, option C 76801, 76802, option D 76805, 76810. The patient is 15 weeks pregnant with twins coming back to her obstetrician to have a transabdominal ultrasound performed to reassess anatomic abnormalities of both fetuses that were previously demonstrated in last ultrasound. What codes should be used for this procedure? And coders, you got 2 minutes to solve this one. And I've already placed the inventory for this question out there. So you got 2 minutes, coders. See you after that. So I believe that's time, and this time I can see some mixed response. So it's going to be a teachable moment. And let's see what we have here. We have a patient who is 15 weeks pregnant with twins, and she has done a transabdominal ultrasound for reassessing the anatomic abnormalities of both the fetus. And again, I've done a chunning here of all the code options which I have, and I have used these guidelines over here to do the chunning. So you can see the CPT code 76801 to 76802 is coding for an ultrasound pregnant uterus with image documentation, fetal and maternal evaluation. First trimester, that means it's less than 13.999 weeks. So that's using a transabdominal approach. And we have 76805, that is for ultrasound pregnant uterus, real time with image documentation, fetal and maternal evaluation after first trimester. That means it's greater than or equal to 14 weeks. The ultrasound is done using a transabdominal approach. We have 76811 and 76812, that is for ultrasound pregnant uterus real time with image documentation, fetal and maternal evaluation, plus detailed fetal anatomic examinations using transabdominal approach. 76811 for the single gestation or the first gestation, and 76812 for each additional gestation. So these ultrasound is done using transabdominal approach as well. And we have 76813 and 76814, which is coding for a knuckle transfluency ultrasound using transabdominal approach. And finally, we have 76815, that's for ultrasound for a quick look, and 76816, that is for reassess or follow up, and use modifier 59 after the first fetus. With that said, let's look into our code options. Option A, 76815, it is incorrect. Why? Because that's for a quick look examination. We didn't have a quick look examination. Patient is here for a reassess of anatomic abnormalities of both the fetus that were previously demonstrated in the last ultrasound. So this is going to be a reassess ultrasound examination. Yes, so option A is incorrect. We are not coding for a quick look examination. Option C is also incorrect, which is 76801 and 76802. That is coding for a pregnant ultrasound pregnant uterus real time with image documentation of fetus and maternal evaluation first trimester. So it's wrong in two ways. This is coding for an ultrasound of a uterus with a fetal and maternal evaluation. We didn't have a fetal and maternal evaluation over here. This is for a quick reassess ultrasound for the anatomic abnormalities of the fetus and not the maternal evaluation. And that is also for 76801 is also coding for less than 13.99 weeks, that is the first trimester. But for us, the patient is 15 weeks pregnant, and that is the second trimester, right? So that means option C is incorrect. And let's look into option D. So I have seen some of them have chosen option D. Option D is incorrect because that's coding for ultrasound pregnant uterus real time with image documentation of fetal and maternal evaluation. So once again, we don't have a maternal evaluation done over here. We have a reassess of anatomic abnormalities of fetus only performed. So with that said, option D is also incorrect. And the last remaining option is going to be option B. That is coding for 76816, 76816 with a 59 modifier. And let's look what 76816 coding for. That is for an ultrasound pregnant uterus real time with image documentation follow up. And you can see in example it said like reevaluation of fetus size. That is going to be our correct answer. that is coding for an ultrasound of a pregnant uterus for a reassess or a follow-up. As been also said, use 59 modifier after the first fetus. So we had a twin. Yes, we have a twin pregnancy over here. So the ultrasound is done for both fetus. So you have to use a 59 modifier after the first fetus. That is for the second fetus as well. So how are you all doing, coders? How are you feeling? Love it. Excellent. So let's feeling great. Yes, so all are doing very good. So let's move on to the next challenge. So correct answer for this scenario is option B. So let me quickly look into the next question. Yes. Okay. What CPT code is or are reported? We have option A 73600, option B 73600, 73610, option C 73610, option D 73600 times 2. A patient arrives at urgent care facility with a swollen ankle. Anterior, posterior, and lateral views X-ray of the ankle are taken to determine whether the patient has a fractured ankle. What CPT codes is or are reported for the service? So, Chorus, your 2 minutes starts right now. I know you don't need 2 minutes to go solve this scenario. You guys are totally doing a good job. So, let's see how quickly you can answer this scenario. I told you, you don't need 2 minutes to solve this one. You all are in a great form today, and yes. So we have a swollen ankle, anterior, posterior, and lateral view X-ray of ankle is taken. And let's look into options. Option A, that's coding for a radiologic examination of ankle 2 views. So how many views are being done here, coders? How many views of an X-ray of ankle is taken in our scenario? Let me know in the chat. Exactly. We have an AP, which is anterior posterior view, and a lateral view. That means we have only two views taken. Yes, only two views of X-ray of ankle is taken in this scenario? And option A, 73600. That's a great option, right? But let's look into other options as well. Mhm. Let's look into the other option. Option B is coding for 73600 and 73610. So option B is coding for radiologic examination of X-ray of ankle, 2 views, and it's also coding for radiologic examination of ankle complete. That means a minimum of 3 views. So that's wrong. We had only 2 views of X-ray of ankle taken. Option B is wrong. Option C is coding for 73610. That is coding for X-ray radiologic examination of ankle of 3 views. Once again, we have said it's wrong. And option D, that's coding for 73600 times 2. We don't need to code 2 times of radiologic examination of ankle with the 2 views, right? It's inappropriate to code a multiplier 73600 into times 2. That means option A is the correct answer. So as I said, the code language in 73600 states 2 views, and it's inappropriate to use a modifier of 2. That makes option D incorrect, and the correct answer is going to be option A, 73600. Great work, coders. You all are on fire today. So let's see. I've got some more scenarios, some more challenges for you. And this is your next question. Select the codes that best describe the encounter. Option A, 76805, 76810. Option B, 76811, 76812. Option C, 76816 times 2. Option D, 76815. The physician orders an ultrasound on patient 25 weeks pregnant with twins to assess the fetal heart rate and fetal position. So select the code that best describe this encounter. So you got this, coders. You got this one. Okay, that's time, and I see. Okay, I see some mixed answers here, I think. Okay, let's walk through. I will walk you through this scenario. So we have a physician who have ordered an ultrasound on patient who's 25 weeks, twins, assess fetal heart rate, and fetal position. And these are our inventory. We have an ultrasound, 25 weeks, twins, assess fetal heart rate and fetal position. So you can see the code options as well. Once again, we are the patient is assessing the fetal heart rate and fetal position only in the scenario. So in our code option 76805, that is coding for an ultrasound pregnancy real time with image documentation of a fetal and maternal evaluation after first trimester. So this code is for a fetal and maternal evaluation. Well, we had only fetal heart rate and fetal position, which is assessed in this scenario, and no maternal evaluation. That means option A, you gotta go. Yes, option has to gotta go. So let's look into the next option, and that is 76811, which is coding for an ultrasound pregnant uterus real time with image documentation, fetal and maternal evaluation, plus detailed fetal anatomic examination. So this has got a lot of examinations performed. It has got a fetal and maternal evaluation plus a detailed fetal anatomic examination as well. We didn't had all those things examined in scenario. It was just a fetal heart rate and a fetal position. So that means option B is also incorrect, and which leaves us with option C and option D. So let's look what they are. Option B and C is coding for. So option D is coding for an ultrasound pregnant real time with image documentation limited, which includes a fetal heartbeat, placental location, fetal position, and or qualitative amniotic fluid volume, one or more fetus. That is also very important. That means we got to only code this CPT one time. Yes, so it includes a fetal heartbeat and fetal position assessment as well. And this is a good option. Let's look what option C is coding for. That is for an ultrasound pregnant uterus real time with image documentation follow-up re-evaluation of fetal size by measuring the standard growth parameters and amniotic fluid volume, re-evaluation of organ system suspected or confirmed to be abnormal on a previous scan, transabdominal approach per fetus. So this one is for a follow-up or a re-evaluation test. That's for a follow-up or re-evaluation examination, which means option C is also incorrect. And in the parenthesis of option T76815, it's also said like U76815 only once per exam and not per element. That also means that we only have to code 76815 just one time. And that is going to be our answer. Yes, so someone is having great time reading this scenario, solving this scenario. Excellent work, coders. I got one more scenario for you all. Yes, what is a CPT code reported for bone density study? Your options are option A 77077, option B 77078, option C 77080, option D 77081. A patient on estrogen replacement therapy ERT receives a DXA study of the hips. What is a CPT code reported for bone density study? So coders, let me once again see how quickly you can answer this question. Your time starts now. Phenomenal coders. I have no words to describe. Excellent. So we have an estrogen replacement therapy, which is a ERT, and patient receives a DXA study of the hips. And what CPT code is reported for bone density study? So this is our inventory. We have estrogen replacement therapy, we have DXA study of hips, and bone density study, which is the same. So these are our code options, and let's start eliminating the wrong answers. Option A, 77077 is coding for a joint survey. We didn't have a joint survey. We have a DXA study of the hip. Yes, so that means option A is incorrect, wrong procedure. Let's look at option B, 77078. That's for a computer tomography bone mineral density study, one or more site, axial, skeleton, example hips, pelvis, and spine. So that is also wrong because the study which is performed is a DXA study and that is not a computer tomography study. Once again, wrong procedure. Procedure option B is incorrect. And let's look into the option D that is coding for. Okay, before that, let's look option C, which is 77080. That is dual energy X-ray absorptiometry, DXA bone density study, one or more side, which is axial, skeleton, hips, pelvis, and spine. So we have done a DXA study of hips. So that is a good answer. That is a great option. And option D, that is for appendicular skeletal. Option D is coding for a DXA bone density study of appendicular skeletal, which includes radius, wrist, and here. So hip is a part of axial skeletal system. That means option D is incorrect. And the correct answer, as most of you have said, is correct. Option C is the right answer. So if you didn't got it wrong, don't worry, coders. You something which you have learned that is precious. So option C is the right answer for this scenario. And I've got one more, coders. I got one more, and this is the last challenge which I have for you all. Okay. So what is the CPT code reported by the radiologist for X-rays? Option A, 73552 with a 26 modifier. Option B, 73590 with a 26 modifier. Option C, 73592 with a 26 modifier. Option D, 73700 with a 26 modifier. A patient arrives at the hospital unable to stand on his leg after collision in soccer game. The patient's shin is sore to touch. Two view x-rays of the tibia and fibula are taken. What CPT code are reported by the radiologist for the x-rays? And your 2 minutes starts right now. And there you go. You did it once again, coders. I can see only one alphabet in the chat. Amazing. So I've already highlighted the keywords here for you all. The patient arrives at the hospital unable to stand on his leg. To view X-ray of tibia and fibula is performed. So inventory we have unable to stand on the leg. To view X-ray of tibia and fibula performed. And these are our code options. Let's quickly eliminate the wrong one. Option A, that is for 73552, is coding for X-ray examination of femur minimum two view. So that is incorrect. We are coding for a two view X-ray of tibia and fibula, not femur. So that means option A is incorrect. Let's look into option D, that is for computer tomography, lower extremity without contrast. So this is a CT examination, computer tomography examination. We had an X-ray of tibia and fibula performed, which also means option D is incorrect. Once again, that leaves us with option B and C. And let me look what option C, B, and C coding for. B is coding for a radiologic examination of tibia and fibula, two views. That exactly matches with our inventory list. Yes, that exactly matches with the keywords as well. So 73592, option C is coding for a radiologic examination of lower extremity infant minimum two views. That involves a complete lower extremity, and that is for an infant. We didn't have an infant we didn't have an infant who's playing a soccer game. No, so that means option C is also wrong, and the correct answer, and the one exactly matches all the keywords and specific matches specificity, is 73590, which is for radiologic examination tibia and fibula to view, option B. There you go. Your answer is option B. As most of you have said, I think everyone said the correct answer for this scenario.
Thank you, Mr. Sandeep, for that incredible presentation on radiology. All right, so now we're down to the wire. I want to remind you to remember to chun your CPT manual. And don't forget to give us feedback. There's only one question, so please and thank you. And while I'm saying thank you, I want to thank you, students. I want to thank you, coders. I'm claiming it. I want to thank Mr. Sandeep. I want to thank the interns for the incredible job they are doing. And I want to leave you with this. It's not about being the best. It's about being better than you were yesterday. It's that simple. All right, coders, until next time.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around the world. AMCI. 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 AMCI.
So let's begin with Path and Lab, CPT code series 80047 through 89398. And now we're going to start with the guidelines. Yes, there are specific guidelines for coding Path and Lab. And again, these are specific and they apply to, these are not specific. These are general coding guidelines specific to Path and Lab coding. So anything within the Path and Lab section, these guidelines should apply unless there is a specific guideline that supersedes it. All right, so the first guideline says services in Path and Lab are provided by a physician, a pathologist, or a technologist under the supervision of a physician. The next guideline pertains to separate or multiple procedures. It says it's appropriate to designate multiple procedures that are rendered on the same date by separate codes. So you can do that, and you can do it without modifiers. Unlisted services or procedures. Well, there are unlisted codes as demonstrated below. And anytime you have to use an unlisted service or procedure, it must be accompanied by a special report or an operative report, or not necessarily operative because we're talking about pathology, but a pathological report. Now, this is the table of contents, and these are pretty much the I would say path and lab procedures or services. Under pathology and laboratory, you will need to know how to code organ or disease-oriented panels. You'll also need to know how to code pathology clinical consultations and surgical pathology. Now, you need to know everything on this list, but these three have nuances, and we will review them today. But for the sake of being consistent, let's go ahead and take a look at what is in the Path and Lab section. Underneath the organ and disease-oriented panels, you have drug assays. It's a presumptive drug class screening, definitive drug class screening, or definitive drug class listing. You have therapeutic drug assays, evocative or suppression testing. Then we're going to go down below pathology and clinical consultations, and you will see the instructions for selecting a level of pathology clinical consultation services. So we're going to talk about that today. Hopefully we get to it. You'll be coding for your urinalysis, molecular pathology, genomic sequencing procedures, and other molecular multi-analyte assays. You have multi-analyte assays with algorithmic analysis, chemistry, hematology and coagulation, immunology, tissue typing, transfusion medicine, microbiology, anatomic pathology, post-mortem examination, cytopathology, cytogenetic studies, surgical pathology, in vivo laboratory procedures, other procedures, reproductive medicine procedures, and proprietary laboratory analysis. So you'll be expected to code for all of these services and procedures. However, these three that we've indicated, they have some nuances. So let's get started with the first one, organ or disease-oriented panel. And what is a panel when it comes to coding? As it pertains to coding, a panel is the way that CPT has developed for a provider to bill more than one test. Example, the provider can stick the patient once and test for several blood tests using one code. All right, Mrs. J, what are you talking about? All right, let's talk about the basic metabolic panel. It's a panel. And the basic metabolic panel has 8 separate tests included in one code. One code, 8 separate tests. And look underneath the code. Underneath the code, you see calcium. Calcium has its own code. Carbon dioxide or bicarbonate, they have their code. So does chloride, creatinine, glucose, potassium, sodium. urea, nitrogen, bun, all of the tests within this panel have their own code. But what is key, 80048 is a panel. And if you are billing for all of these tests, you must use this panel. Anytime you fail to use the panel and you code any of these separately, it's considered unbundling, and that's fraud. All right. So here's an example of unbundling. If a basic metabolic panel was carried out and the coder builds all of the codes separately instead of 80048, that's unbundling. Now, I want to move on to how to code a disease-oriented panel. If you've done the homework, you probably already know. All right. Yeah, someone said, hey, they love panels, but it could be a little tricky. I think if you really employ these FTRs, the trick will go away. Okay. All right. So FTR, here are the facts to remember. Number one, when coding these disease-oriented panels, do not code these tests separately when you have a panel. It's unbundling. Number two, all tests within the panel must be performed to use that panel. Number three, report additional tests not within the panel separately. Number two, if you have two panels with overlapping or the same tests, code the larger panel of the two, then code the remaining tests separately. Number five, do not report two or more panels if they have the same tests. Number six, do not split a panel. Don't use modifier 52 with a panel. All right, so hopefully, I'm going to let that marinate a minute. Boom, and this is also your FTR. If you go to your MCG and you look up panels, these FTRs are there. So have you read the pathology chapter on panels in your Bucks book? Go ahead, type in the chat. Let me know. Anybody have time to read it? Exactly. All right, let me go. Let's see. All right, so most of you said, no, I'm not reading that book. Okay, so if you can, please. All right, you don't have to, but it will seal the deal. All right, so I got a question for you. How many tests are in the panel? All right, so we have 80053. Go ahead, type your answer in the chat. How many tests are in the panel? Outstanding. Those numbers are coming through. They're coming through. They're coming through. Good deal. All right, so I'm going to count. The answer is 14. Albumin, 1. Bilirubin total, 2. Calcium total, 3. Carbon dioxide bicarbonate, 4. Chloride, 5. Creatinine, 6. Glucose, 7. Phosphatase alkaline, 8. Potassium, 9. Protein total, 10. Sodium, 11. Transferase alanine amino, 12. Transferase aspartate amino, 13, and 14, urea nitrogen bun. So there are 14. So it's simple as just counting. In this case, I got another question for you.
How many tests are in the panel? Okay, coders, 80050. General Health Panel. How many tests are in the panel? All right, I'm going to give you a moment or two. Type your answers in the chat. Okay, how did you do? If you said the answer is 17, outstanding. All right, now let's go ahead and determine how we arrived at 17. Okay, the first, let's just take a look at the contents of the panel. A general health panel 80050 contains the following. It contains a comprehensive metabolic panel 80053, and we've already determined that that is 14, right? So we in the previous slide we determined that it was 14. So a comprehensive metabolic panel is 14. Then you have to include your blood counts. You got 2 blood counts. All right, this blood count, the first one, includes a CPC automated with automated differential WBC count, and that code is 85025 or 85027. So it's either or, and 85004. All right, so it's 85025 or 85027 and 85004. So 85025 is one lab, 27 is one lab, and 85004 is one lab. So for this complete blood count with automated differential, you could have a maximum of 2 labs. So it's either or, okay? Now, so either your general health panel is going to include the first CBC or the second. The second below, let me get my little pointer so you know where I'm pointing. This blood count complete CBC automated 85027 and appropriate manual differential WBC white blood count 85007 or 85009. All right, so let me get rid of this so I can count. So the first CBC is one lab. The next is 1, or you're going to include an 85009 or 1. So the bottom line is the maximum number of labs for this CBC is 2. And it also includes the thyroid stimulating hormone, or TSH, 84443, and that's 1 lab. So we're going to add 14 plus 2 if the first blood count was carried out, or plus 2 if the second one was carried out, and we're going to also add the TSH. So you're going to have 14 plus 2 plus 1 equals 3, and that total is 17. Okay, all right, team. Hopefully you understood that. And if you got that correct, outstanding.
Important that you CHUN your sections. CHUN the pathology disease panel. So this is how you do it. You go to each one and you place the number of tests next to it. So when you're testing, you can see right away. You know what I mean? Check my numbers, please, and thank you. Mr. Sandeep, let me know if these numbers are accurate, but I'm pretty sure it's 19 tests. 80050. And if I'm incorrect, I will come back next week and I'll tell you, but today I'm pretty sure it's 19. All right. So do you see how you should place your test, your number of tests? So go ahead and screenshot and do this in your CPT manual, panels section. All right. Coders, are you ready? Somebody says, hey, doesn't the CPC include the WBC? Yes. So that one code 85021 is one and 85004. Absolutely. Good eye. All right. So are you ready for a coding exercise? Let's do it. Which of the following panels does not include chloride? Okay, coders. It says you have 1 minute. Your time begins now. How you doing? Okay. You all are rocking it. So what does not include chloride? We're going to go to our panel. And if my numbers are wrong on the slides, that 19 is wrong, please forgive me. All right. So we're just going to look up each one of them. And we're going to begin with 80053. The reason is because this is the comprehensive metabolic panel. And I see that chloride is here. So I'm going to eliminate it. However, we've just completed the general health panel, and this comprehensive metabolic panel is a part of it. So it too has chloride. I'm going to let that marinate. So both C and D, excuse me, C and B need to be eliminated. Now that leaves us with 80047 and 80061. Let's look down and see if chloride is here, and it is. So we're going to get rid of D, and that leaves us with 80061. There's no chloride in the lipid panel. And if you said A, outstanding. All right, let's try another one. The correct codes for these procedures are A, 83718, 82465, 84478, 82947, B, 83721, 82465, 82951, C, 80061, 82947, D, 80061, 82950. The physician performs the following tests on her automated equipment. HDL, total serum cholesterol, triglycerides, and a quantitative glucose. Okay, coders, you have 2 minutes. Your time begins now. Okay, I wish I could see you as you are typing, but I can't. Outstanding. Someone said they can't find them. Look in the section we're talking about. These are tests, okay? And this is in the disease panels, okay? All right. So even if you can't find them, you can find them within panels too, right? Okay, so here are our keywords. HDL, total serum, triglycerides, and quantitative glucose. Well, here are our codes. We have a lipid panel, and it also, within that panel, has cholesterol serum. So we know one of them is there, that 82465. The lipoprotein direct measurement high density cholesterol, or HDL cholesterol, 83718. Also, your triglycerides are here, 84478. So all of your codes are there. And if we go back to our FTR and we remember that the guideline says do not code tests separately when you have a panel. So all of these tests should not be coded separately when you have a panel. So I see that happening. Okay. So we're going to hold on to this lipid panel. So we know that 83718 is coded, 84478 is also being coded here, and 82465 is being coded separately. We've got a panel. So we got to use our panel, and A is going to be incorrect. B is going to be incorrect on the strength that it's not coding for what we need. We know at least we need a panel, and B is not coding for that panel, because the guideline tells us that we must report a panel if all of the tests are carried out. So the only thing left that we have to code is that quantitative glucose. All right, so we've got a quantitative glucose blood, except the Regent strip. That is likely our code, and 82950 is not. And that is the difference between C and D. C is coding for the quantitative blood glucose, whereas D is coding for it's coding for glucose quantitative. It is, but glucose post-glucose dose. It's not coding for quantitative, See the little parentheses? I apologize. All right, so we're not coding for that post-glucose dose. You gotta go. And C is our answer. So if you said C, outstanding. And you know what? You're doing good, you're doing good. So my question to you, does that make sense? Go ahead, type your answers in the chat. I see one yes. Okay, someone says so far. Yeah. And you know what? If this makes sense, and if you get this, you're going to get them. You're going to get them all. You are. So have confidence. Just trust it. All right, so here is this the last one? Yeah, here's our last one. How should these services be reported? A, 80053, 82248, 86709. B, 8005322 modifier. C, 8007652 modifier, 8007452 modifier, 8005352 modifier, and D, 80047, 80053, 80076. A patient had the following blood tests completed as a part of her primary care physician's described metabolic panel: albumin, bilirubin total, calcium total, carbon dioxide, chloride, creatinine, glucose, phosphatase, alkaline, potassium, protein total, sodium, transferase, alt-SGPT, transferase, aspartate, AST-SGOT, urea nitrogen or BUN, bilirubin direct, and a hepatitis AIGM. All right, coders, what say you is the answer? And you've got 2 minutes to solve. Look at that. Look at you all. Some people are answering right now. What? All right, take your time. All right, all right. I think a lot of you just nailed this. All right, this is what I did. I just said, all right, we've got the test completed. I started documenting these tests. They said it was a metabolic panel. Which one? Is it a comprehensive metabolic panel? Is it a basic metabolic panel? Don't know. So we're going to just go ahead and document all of these tests, right? Yeah. And you know what? It's looking like a comprehensive, what is it looking like? It's looking like a comprehensive metabolic panel. Maybe, because we just said that the comprehensive metabolic panel had 14 tests. As you can see, we have 16, right? Okay, so let's see if we can get a panel out of this, right? And let's start with our comprehensive metabolic panel. Let's see what's in there. We know we have 14 tests, and look at it. You've got your albumin, your bilirubin, it's in order, your calcium total, your carbon dioxide bicarbonate, your chloride, your creatinine, your glucose in order, your phosphatase alkaline, your potassium, your protein total, your sodium, your transferase alanine, your transferase aspartate, your urea bun. So all 14 of these tests were carried out. So our guideline says that when you have all of them, you need to code a panel. So all of these were carried out. And I'm going back down to my FTRs. It says do not code these tests separately when you have a panel. All tests must be performed to use a panel and report additional tests separately. All right, so we've got 14 here. There are 2 additional tests. How do we know? Because we wrote them down initially. So we can eliminate C and D, right? On the strength that we have a panel. And C and D is not coding for that panel. Well, C is coding for the panel, and D is also coding for the panel. So maybe we're not going to eliminate them. We can eliminate C because look at the last FTR. It says, do not split a panel. Do not use modifier 52. And C is doing that. So we can eliminate C right then. All right. Also, 82274, this is bilirubin direct. That's what's left over. And so 2 is the hepatitis A IgM. That's also left over. 86709. So these 2 tests are your remaining tests, and A really is coding for the panel correctly and the remaining tests. So we know A is the answer. We're eliminating C because they use the modifiers. We're eliminating B. What's that 22 modifier? Nothing that says that this was a increased procedural service. And D, 80047. And also, too, I don't think you can use modifier 22 on these. Just saying, I don't think. I'm going to research. All right, 80047 was not, this is a basic metabolic panel, and they have the same, a lot of the same codes as a comprehensive, so it's not comprehensive enough, and we're going to get rid of you. And 80076 is a hepatic function that wasn't carried out. So you all got that correct. And you know what? I don't think you'll see anything that complex on your exams. And if you understood that, then you're doing really good. I hope you feel good. Because a lot of you did say A, outstanding. Now we're going to turn our attention to pathology clinical consultations. These are, when we say consultations, we think of doctor visits and when we go to the doctor to get a consultation. But think of it as tissue and reports having the consultation. Yeah, so the patient doesn't necessarily go, but the patient's reports go to the pathologist for a clinical consultation. All right. So the pathologist he'll read your test results, study those results, and come up with a conclusion or a diagnosis. Indeed, and often the pathology works with surgeons and other specialists to they correspond, and they both often come up and agree on the patient's diagnosis, final diagnosis. So let's see how we code this. And we're going to do this by looking at some of the guidance. And this guidance is right above the code series. And there are 4 codes that you'll be required to use. And you'll also have to meet some basic guidance, some basic guidelines before you use the pathology clinical consultations. First of all, you must have the 3 R's in your documentation. That means a request has to have been made by another doctor. Number 2, that pathologist has to render the service. And number 3, the pathologist has to provide a written report. So whenever you get your documentation, the first thing that you need to look at is if the 3 R's are there, and then you can consider this as a pathology clinical consultation. So as I've said previously, there are only 4 codes that you use, and we're going to take a look at these codes and see how they're distinguished. Now it says, and then write the 3 R's that I've just told you about. The guidance is right here in the blue. That's where I got it from. Now, how do you select the level of consultation? The level, these 4 codes are levels. One is a level 2, level 3, level 4, and level 5. I believe it's level 2, 3, 4, and 5. I believe so, but we're going to take a look at the codes. How do you select it? Well, you're going to select these codes based upon the medical decision making that the consultant uses. So we're going to look at the documentation and determine how complex the encounter was. Or we will determine the level of service based upon the total time that the consultant documents. Now, total time is straightforward. We like that, right? Yeah. And some of these items are at the doctor's discretion, but, well, it's the doctor's discretion whether they're going to use time or MDM. All right. Now let's go ahead and look at codes 8, 0503, 04, 05, and 06. And let's look at what distinguishes them. All right. So 80503 is what we call straightforward medical decision making. So the provider did not have too much to do, and the provider could come and arrive to the decision making very easily. It was straightforward. And if we were to quantify straightforward medical decision making in terms of time, straightforward decision making would take up between 5 and 20 minutes of total time. Now, 80504 We call this moderate level of decision making. And to arrive at the medical decision making, the amount of time should take 21 to 40 minutes of total time. 05, this is high level of medical decision making, and the total time is 41 to 60 minutes. So that's how long it takes for that encounter. And then 80506, this is your prolonged service code, your add-on code. For each additional 30 minutes, you append 80506. So pretty much we have 3 basic consultation codes, 1 add-on code for a total of 4, and the code selection is based on the amount of time of the encounter or the medical decision-making complexity. So time is pretty straightforward. And I don't know, yeah, we're going to do some examples with time and medical decision making. All right, but before I move on, there are 2 types of consultations in the pathology section. So one is pathology clinical consultations, and then you also have pathology consultations. The clinical consultations are more extensive, and it takes more time. Whereas the pathology consultations, they're not as extensive. In fact, the consultation just involves tissue, right? So if you look at 88321, that code is used when the pathologist is asked to render a decision that was referred from elsewhere. 88323, the consult involves and requires that the consultant prepare slides. 88325, this requires the consultant to review records and specimens with report on the referred material. It's not as complex, and these don't take a lot of time. But both of these consultations require the 3 R's: a request, a rendered service, and a report. So try not to confuse the 2. You'll know the difference. A clinical consultation is going to be written. It's going to be written up like a consultation, and we're going to take a look at some of them, okay? So just so you know, we're going to focus our attention on clinical consultations, and remember, the doctor can choose how they want to document it. They're going to either tell you the total time, or they're going to give you the documentation, and we're going to have to determine the medical decision making based upon their documentation. Now, the one I'm going to start with is total time, okay? Sorry, I got a little ahead of myself. Now let's take a look at the codes. If you go to 80503 through 06 above the code series, they have some guidance. And this is what the consultant is doing during their encounter. And these are appropriate activities when they're using time. So even though it's their discretion, they have to be doing the following, any of the following. Right here, review of available medical history, including presenting complaints, signs and symptoms, personal and family history. They can review test results, review all relevant past and current lab pathology and clinical findings, they can arrive at a tentative conclusion, differential diagnosis, comparing against previous study reports, including radiographic reports, images as applicable, and results of other clinical testing. They can order or recommend additional or follow-up testing. They can refer and communicate with other healthcare professionals, not separately reportable, and they can do some counseling and educating the clinician or other qualified healthcare professionals. They can document the clinical consultation report in the electronic or other health record. So time spent doing any of these are qualified. Now, are you ready? Okay, coders. Now it says, what are the CPT and ICD-10-CM codes? RMANS, oh, excuse me, no, let me go ahead and read the answers. I apologize. A, 80505, R1 8.8, I10, K2 1.9, B, 80504, R1 8.8, I10, K2 1.9, C, 80506, R1 8.8, I10, K2 1.9, excuse me, 80503, 80506, R1 8.8, R6 0.9, I10, K2 1.9. Armance, MD, requested Dr. Rogers, pathologist, to provide clinical consultation for the following patient: Lily Bloom, 26 years old, diagnosis, abdominal pain, cytology report, collected 2/3/2023, received 2/4/2023. Pathologist performing the service is independent. Source: biopsy tissue and report, abdominal tissue, and fluid analysis report. Pertinent clinical data and clinical diagnosis. 26-year-old female, a history of hypertension and GERD, has complaints of abdominal pain and swelling. Laparoscopic biopsy of abdominal tissue was inconclusive. Abdominal tissue and fluid analysis revealed abnormal findings. I was asked to provide independent review. Cytologic impression, abdominal tissue and fluid analysis. No cytological malignant cells are identified. Biopsied abdominal tissue analysis. No cytologically malignant cells are identified. Patient diagnoses. Non-malignant ascites or ascites, source unknown, and edema associated with hypertension. Patient referred to gastroenterology for further workup. Time, 60 minutes. All right, coders, what say you? Go ahead, type your answers in the chat. Good deal. Good deal. I see a mixture. You are saying A or D. So let's go ahead and do our due diligence. All right. So, question, was the 3 R's carried out? Can we code this as was the 3 R's? Obviously, because we only have these codes. So, here are my keywords, and I'm going to point it out on the next slide. The 3 R's, yeah, they were carried out. I'm gonna do it right now. Yeah, we had a request, right? We had a report, right? And we also had a cytologic impression. So the doctor rendered the service and a diagnosis. Now I'm going to my codes, 80503 through 80505, and we see A has 80505, B 4, C6, and D3. Now, time was documented, right? Time was documented as 60 minutes. So the level of service will be dependent on the time. So if we look at A, the time spent to use 80503 is between 5 and 20 minutes. 04, 21 to 40 minutes. 05, 41 to 60 minutes. And if 06 was sequenced first, that's an add-on code. We're getting rid of that right away. So C got to go. Nobody said C. Outstanding. So the answer is A, 80505. Because the times match. All right, how you doing? Outstanding. And you know what? We have to pick the best of the 4. Let's say the diagnoses codes were all messed up. On this test, you have to choose the correct procedure code, especially if all the procedure codes are different. You don't even have to look up the diagnoses. You all are rocking it. Okay, now we looked at how you consider time. It's time to turn our attention to medical decision making. Now we have to look at the clinical documentation to determine the medical decision making. Now, this is a little more detailed, and a lot of people like it. And some people are like, I don't want to read all that, but you know what? We're coders and we should love it, right? So we need a chart. We need a chart, and this chart is in your pathology section. And essentially, we're going to have to determine the number of problems and diagnoses that are in that documentation that this doctor had to address. So we need to know the number of problems and the complexity of the problems that the doctor had to address. And it's basically counting. Also, we're going to have to measure the data, the amount of data that the doctor analyzed. And then we're going to go to the third column and we're going to measure the risk. What is the risk of morbidity or mortality of the patient? And these elements give us guidance and they tell us how to do it. And then once we make our determinations, is if it's a low level, a moderate level, or a high level, then we'll have to select our code, and this is how it's done. It's easy if all of the problems, data, and risk fall on the same level? It's easy because we know if you have a moderate problem, a moderate data, and a moderate risk, your answer is going to be moderate. However, if any one of the elements falls on a different level, we're going to have to do what we call level. And we're going to have to select the code using the leveling process. And this is done by just throwing out the lowest code and coding the next lowest code. So this is how it's done. What if we had a high problem and we had a moderate data and a moderate risk? We have to level because all of the elements are not on the same level. And how it's done? You throw out the lowest. So let's throw out one of these because they're both moderate. Throw out one of the moderates. And then you code the next lowest level. And the next lowest is still moderate, right? Moderate's lower than high. So it's a moderate medical decision making. I just thought I would show you that. Now I'm going to show you how to read this chart by using documentation. All right? So I'm going to walk you through this. Now this is the same documentation, right? But this time, even though it's 60 minutes, we're going to not use time. We're going to use the medical decision-making option, okay? All right, so let's say the doctor says, no, just, pretty much score my medical decision making. Don't use the time because I think I can get a higher level. Okay, so we're going to do it. All right, so we know that it meets the definition of a consultation because we had our request. We also had this the report and also the service, and a diagnosis was rendered, right? All right. So now we'll need to look at all of the problems, the data, and the risk, and we're going to assess it to determine the level of service. So first things first, we have to determine the number and complexity of the problems addressed. In other words, diagnoses, signs, and symptoms, right? So I'm going to go to the final diagnostic statement, which is right here, this cytologic impression. I'm going to go to the assessment and the plan or impression of any documentation. So in our case, we have cytologic impression, and I'm going to look at the final diagnoses, right? The final diagnoses are non-malignant. Oh, I wish I wouldn't do this in this order. All right, and then, okay, so that's what I'm going to do. I'm going to announce and let you know what those problems are. And then also, when I finish evaluating the diagnoses and the problems, I'm going to go to the data. And then we're going to look at the data and the tests that the pathologist carried out. And then finally, we're going to measure the risk. And we're going to use this chart. All right, so let's start with the column number 1. We need to know, is this low, moderate, or high problems? So I got to go to my cytologic impression and look at the final diagnoses. We have a non-malignant ascites. We have edema that's associated with hypertension. So I have to look on this chart to see if these problems fit. So let's start with low. Remember, we have non-malignant ascites, edema, and hypertension. So it is low if there were 1 to 2 laboratory or pathological findings, or if there were 2 or more self-limited problems. Well, I'm going to say no. And also, in your book, they define what self-limited is. I don't have enough time to do it because I'm going to do it next week when we talk about E&M. But let's say we don't have the definition, but we do have moderate, and let's see if any of these terms make sense, and let's see if our problems kind of fall there. I don't think these are self-limited. I think they're more severe than that. So let's go to moderate. It says 3 to 4 laboratory or pathological findings. Well, we probably have about 3. But I like the one underneath it. It says 1 or more chronic illnesses with exacerbation, progression, or side effects of treatment. I like this because I know the definition of a chronic illness. The definition of a chronic illness is any condition that the patient is going to have for a long time or long period. That's the summarized definition. And we'll talk about it next week when we discuss evaluation and management. So we know hypertension is a chronic illness, right? And the exacerbation means it's getting worse or worsening or progression or progressing. And I think so because the doctor says that the patient has edema that's associated with hypertension. Now, everyone that has hypertension, they don't have swelling. But in this case, the consultant is saying, hey, that edema is associated with that hypertension. And so therefore, it is an exacerbation or worsening of the condition. Or it could fall under 2 or more stable chronic illnesses. Somebody might say the non-malignant ascites is a chronic illness because it's going to be, the patient may have it for a length of time. However, that's an assumption because it says this ascites, the source is unknown. So if it's unknown, you can't say that it is or isn't going to, be for, exist or last for an extended period. So we can't really say that. I still like this 1 or more chronic illness with exacerbation. Then we have 1 undiagnosed new problem with uncertain prognosis. Yes, that non-malignant ascites is the source is unknown. So it is a new problem and it's undiagnosed. Or you have 1 acute illness with systemic symptoms. This could be acute, and the systemic symptoms, I don't see any systemic symptoms, but it could be. But I like this 1 or more chronic illness, so I'm going to say this is moderate. Are you all with me? People are writing me notes and I'm looking at it. Okay, so people say they're with me. All right, so now let's look at the data analyzed. All right, so we have to view the data and the test that the pathologist carried out. So let's look at number 1, and I do apologize for this being so small, but go ahead and take your you have a enlarger. Zoom if you need to. All right. All right, so let's look at number 1. It says you must meet the requirements of at least one of the 2 categories. So we have a category here and a category here. In order for it to be low, you have to have any combination of 2 from this category. So the patient, the doctor had to review prior notes from each unique test. Okay. So he reviewed 2 tests, did he? Or 3 tests? Yeah, let's see what he did. There was abdominal tissue analysis, abdominal fluid analysis, and biopsy tissue. So he's got 3. So that's 1. Review of results of each unique test. I believe that happened. Oh no, did he review the prior notes? Let's see, did he review notes? I don't see any notes, but he did review the tests. So he met 1, 2. All right, what about ordering or recommending additional follow-up testing? I don't see that. All right, so it says, or assessment requiring independent historian. Okay, that didn't happen. He didn't do that. But he did meet category 1, must meet at least one of the 2 categories, and he met category 1. So I'm going to moderate. We're going to go down. And moderate says must meet the requirements of at least one of the 3 categories. All right, so review of prior notes from each unique source. We already said no notes. Oh, wait. Yes, he did. Biopsy tissue and report. He reviewed those notes. Good deal. I do see that. So yes, he did. Review the results of each unique test. He did. The tissue analysis, abdominal fluid, biopsy fluid. Ordering or recommending additional follow-up testing? No. Oh, wait. He didn't say testing, but just go to gastroenterology. Assessment requiring an independent historian? No, that didn't happen. But it says any combination of 3 from the following, and each test represents a unique source, and he has 3 tests. So he does meet this. Any combination of 3 from the following. Any combination of 3 means each unique test, 3 tests. Or independent interpretation of the test. Absolutely, he did. It said it twice in this documentation that this doctor is performing an independent service. I saw it here and I saw it somewhere else. Here and here. So he meets that too. So he meets category 1 and category 2, and it says you have to be 1 or 2, or discussion of management of test interpretation. There was no discussion with another practitioner, so we're going to eliminate category 3. And now I'm going down to extensive. Let's look. All right, he must meet the requirement of at least 2 out of 3 categories. So you got to have 2. Oh my goodness, he did. You know what? I'm going to change my answer. He did, because he has 3 unique tests and did an independent interpretation. OMG. So we're going to, come on. All right. Yeah, I'm going to say it's extensive. Are you watching this, Mr. Sandeep? He's probably shaking his head like, what? Okay, so my star, I messed up my star. Sorry about that. So I think it's extensive. Yes. All right, so this is independent. It's not moderate. I'm going with extensive. Huh. Oh no, I'm messing up the, come on. I think it's extensive. So
Sorry about that. No, we're going back. Mrs. J is going back. All right, I thought I moved this. It doesn't change my code at all. There you go. All right. So my problem is moderate. My data is extensive. My risk, well, let's read it. It says it's a low risk of morbidity for additional diagnostic testing or treatment. So it's kind of subjective. Risks are always subjective. Now let's go to moderate risk of morbidity. The examples are prescription drug management, decision regarding minor surgery with identified patient or procedural risk factors, decision regarding elective major surgery without identified patient or procedural risk factors, diagnosis or treatment significantly limited by social determinants of health. It's not there, but let's look at high. It's a high risk if drug therapy, these are examples only, requiring intensive monitoring for toxicity, decision regarding elective major surgery with identified patient or procedural risk factors, decision regarding emergency major surgery, or decision regarding hospitalization. So coders, none of these or remotely, the doctor just referred the patient to gastroenterology. So I'm going to say this is a low risk. Now we have to determine our level. And remember, I said to determine the level, if all of the stars are on the same row, that would be easy. We would just code that row. But we have stars on all 3 rows. And what is the rule? The rule is you have to throw out the lowest level, and that's right here, low, and then you code the next lowest, and that's moderate. And there's your code. And you can see, even if it's kind of subjective, and even if you disagree or agree, 9 times out of 10, you're going to arrive at the same answer. Let's say somebody says, well, I think this is 3 or more pathological findings. And somebody says, no, I think it's like 1 chronic illness with exacerbation. As long as you're in the right ballpark or the right area, often you're going to just arrive at similar levels. Okay, coders, are you with me? All right. Good deal. Somebody said, I'm with you. About 3 people, everybody else is like shaking their head. What? No, trust me, all you have to do, you keep reading these charts and you'll get used to it. And you're going to get a lot of practice because evaluation and management involves the same thing. So you'll be accustomed to these definitions, and trust me, you've got it. All right. Let's try. I want you to try this coding exercise. Now, this is a clinical consultation, and it's an MDM, medical decision making. All right. What is the appropriate level of service? A, 80503, 80504, 80505, and D, 80505 and 80506.
The pathologist, Dr. Blank, was requested by Dr. Jones to carry out a clinical consultation to determine if a patient has breast cancer. The patient has a history of multiple painful breast lumps. The pathologist reviewed the patient's chart that included mammography, MRI, and ultrasound. Also, Dr. Blank microscopically analyzed the tissue from previous biopsied breast, axilla, and surrounding tissue. The case was uncommon and required Dr. Blank to confer with the patient's radiologist for clarification. Dr. Blank reported back to Dr. Jones his findings and the final diagnoses. Non-cancerous fibrocystic breast. All right, cutters. You have 2 minutes to solve. Your time begins now. All right, I see ABC, ABC. And someone said the chart helps. Good. All right. All right. So also on purpose, I haven't been inventorying, but now I'm going to show you that inventory kind of works too. So here are my keywords. We have this was requested by Dr. Jones, clinical consultation, want to determine if the patient has breast cancer, mammography, MRI, and ultrasound were carried out. Tissue was analyzed from biopsies of the breast, axilla, and surrounding tissue. Dr. Blank even conferred with a radiologist, and Dr. Blank did report back to Dr. Jones. His final diagnosis is non-cancerous fibrocystic breast. All right, so this is indeed a clinical consultation. The 3 R's took place. We had a report, a diagnosis was rendered, and a request. Request, report, and rendered diagnosis. Now, this is how we do it. All right, so when it comes to the problems, we pretty much are going to look at the number of problems addressed. It's a little different. There are going to be problems, but diagnoses too, right? And so you pretty much get it in the final diagnostic statement. So the doctor said, hey, there's non-cancerous fibrocystic breast, and they also said that this patient had multiple painful lumps. So you're going to list the problems, right? The definitive problems. So I think that there is one or more chronic illness with exacerbation. That's what I think it is, because this is fibrocystic breast, and this patient might have this for the rest of their life. And the problem are the lumps and the pain. That's the exacerbation or side effect, or not side effects, but progression. So I'm going to say it's moderate. Then I'm going to look at the amount of data analyzed. This is what the doctor did, right? So I'm going to document what he did. He looked at the patient's chart with the mammography, the MRI, the ultrasound. He also looked at tissue of the breast, axilla, and the surrounding tissue, and he conferred with a radiologist. So if we look at number 1 under amount of data analyzed, must meet the requirements of at least one of the 2 categories. Here's category 1, here's category 2. You already know we've exceeded category 1 because he reviewed prior notes. So he reviewed the patient's chart for the MRI from each unique test. He had a mammogram, MRI, and an ultrasound. That's 3. That's 3. And you only need 2. So he exceeded that. So let's go down to moderate. All right. So you have to have at least one out of 3 categories. Here's 1, 2, 3. So the first category says that you have to have your test documents or independent historian, any combination of 3 from the following. We got 3 tests, so we meet it, right? We meet it, 3. Or category 2, independent interpretation. Well, there's no mention that there was an independent interpretation. Or discussion of tests. And he did discuss it. He did. So I'm going down to extensive. Must meet 2 out of the 3 categories. Well, we know he met category 1. These are identical, but you only have to meet 1 out of 3 up here. Down here, you have to meet 2 out of 3, 2 out of the 3 categories. So we met category 1, and we also have met category 3 because he talked to the radiologist. So 1 and 3 were both met, 2 out of these 3. So this is extensive data. Now, what about the risk? All right, so there's really nothing documented for low risk. So let's see if it falls under moderate. Were any prescriptions done? No. Decision for major or minor surgery? No. Diagnosis of treatment significantly limited by social determinants of health? No. No mention of that. And high definitely doesn't. So this is a low risk. Okay, coders, now that we have my stars, my elements selected, go ahead and level it. Tell me what is the correct level of service. Is it low, moderate, or high? Go ahead, type your answers in the chat. All right, so this is how you level. Throw out the lowest, code the next, and it's a moderate level, 80504. And if you said B, outstanding. All right, so we have about 2 minutes, and I'm going to walk through the next one, and then we're going to go. All right, so this is a time-based one. So you all might be able to get this before me. All right, so no malignant cells were identified. What are the CPT and ICD-10-CM codes? A, 80503, N18.6, E10.9, Z 99.2, B 80504. Go ahead, you all can do this. You all can do this. We're looking at time, right? Yeah. All right. 80504, N18.6, E10.9, Z99.2, C 80505, N18.6, E10.9, Z99.2, D 80503, 80506, N18.6, N10.9, Z99.2. This is requested by R-Mans MD. Cytology report collected 2/3/2023, received 2/4/2023. Pathologist performed the service, is an employee of the lab. Specimen source: A, peritoneal fluid. Specimen description: 100 milliliters, yellow fluid. Cyto preparation: 2 CCF. Pertinent clinical data and clinical diagnosis: 30-year-old male with end-stage renal disease due to type 1 diabetes presents for elective kidney transplant. Cytological impression: peritoneal dialysis, drained fluid. No cytologically malignant cells are identified. Comment: 100 milliliters yellow fluid is received from which 2 Papinocolo. I don't know how to pronounce that, but I know what that is. Stained, but I'm thrown off a bit because I know what it is. Cytocentrifuged slides are made. Slides contain mesothelial cells with a spectrum of reactive changes and histiocytes. No malignant cells are identified. Very good. Papinicolo. I gotta get that. All right, you all are rocking it. They're putting the answers in the chat. Here we go. All right, so we know this was a request, right? We know that we're looking at peritoneal fluid. We know the patient's problems, end-stage renal disease, and type 1 diabetes, and he's there for elective kidney transplant. This is a 30-minute encounter. All right, so we have to have a minimum of the 3 R's. We do. A request, service was rendered, and he reported back to the provider. The coding tips: codes are selected by MDM or time. We have time documented 30 minutes. So let's go to our codes. 80504, pathology clinical consultation for moderate complex clinical problem with review of the patient's history and medical records and moderate level of MDM. The time is 21 to 40 minutes. This is our code. The others don't fall. The other times are not applicable. So if you said B, the answer is B. Outstanding. And I think we all love the time, right? Yeah, I love the time too. But as long as it carries out, as long as the following are carried out in these activities for the consultant are documented right above the code if you want to reference them. All right, so that concludes. And due to time constraints, you will have to view the medicine section on your own. We've created a lecture that you can find on the playlist, and I'll point it out when we review the homework. Speaking of homework, we're going to review it after we talk about what we've learned. What did we learn today in week 15? Well, we reviewed radiology, path and lab. You're going to view your medicine independently from your playlist. We practiced exercises to test your knowledge, and hopefully we brought you one step closer to CPT coding mastery. How about that path and lab? Wow. Now let's review the homework. All right, so go to the website www.amcicoding.com, click on YouTube course. At this juncture, you know where it is. Your syllabus is here. Just scroll down the page. You'll find your syllabus. If you need to review the books, you can find the textbooks on that page as well. Now, here is the homework. As you can see, there are 17, so prepare accordingly. Number one, the class PowerPoint. If you want to follow along, watch the playback and follow along with the PowerPoint, you can get it in Discord. Number two, go ahead and watch this playback. If you need to watch this class again, you can click that green hyperlink. Number three, we have a supplemental radiology lecture. Yes, and we encourage you to begin at 1 hour, 25 minutes, and 10 seconds. However, if you want to review the anesthesia portion, just watch the whole thing. Number four, your reading assignment. It's on radiology and it's Unit 3, Chapter 4, and Carol Buck's Step by Step. Number five, watch the CHUN lecture on radiology from your MCG manual. Number six, optional, how to code a long operative report on radiology. Number seven, time to CHUN. Go ahead and CHUN your CPT manual radiology section. You have to join our CHUN group. The link is on your syllabus. After you join, you click on media, then album, and boom, you'll see all of the CHUN according to the chapter. Number eight, complete your quiz on radiology coding from your MCG manual. We call it beta quizzes. Number nine, go ahead and read Unit 3, Chapter 25, Path and Lab in your books, step by step. Number 10, there's an optional watch how to code an operative report on pathology. Number 11, CHUN your Path and Lab section. Number 12, complete your Path and Lab quiz. Number 13, go ahead and watch the medicine playback. It's been included in your playlist. Okay. Number 14, you got a reading assignment, Unit 3, Chapter 26. It's on medicine in your step by step by Bucks. Number 15, you have an optional assignment, watch how to code an operative report for long anesthesia scenarios. Number 16, CHUN the medicine section of your CPT manual. Number 17, go ahead and complete the medicine quiz. You can access it from MCG. And finally, if you have time, go ahead and listen to the corresponding podcasts. Yeah, they're really good. And don't forget about Friday Night Live, 7 p.m. Eastern. Don't forget about Wednesdays, I'm Tap, interactive medical terminology, anatomy, and physiology. And next week, we will discuss evaluation and management. And yes, we will talk about exam prep. Yes, exam prep for all. We're going to discuss CCS and we're going to review CPC and CCS-P. All right. Don't forget to fill out the survey, coders. It helps us help you. And if you like this presentation, please give us a thumbs up. If you didn't, thumbs down. And I just want to say thank you. Thank you to my amazing team. You are the reason. And thank you too, coders. I want to remind you to keep pushing, stay precise, and trust the process. Excellence is built one code at a time. Okay, coders, until next time.
4,000 exam passers and free classes at AMCI. Learn to go straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around the world. AMCI. AMCI.